Thank you for joining us today. My name is Nicole Schneider, and I'm with Alicia Burma, and we work for the State of Wisconsin Medicaid Agency. So I wanted to explain a little bit about Medicaid is a really big, complicated organization, as I'm sure you know if you've tried to navigate receiving services through Medicaid. In our state, we obviously have a governor who's elected by the people. He appoints a secretary of health who appoints a Medicaid director. And then within the Medicaid director, he's hired 3 administrators. And I am the administrator over benefits and service delivery. So how we write benefits and how we deliver services in Medicaid. There's another administrator who works with all of our systems. So how claims get paid, how folks are enrolled in a system, and she has systems, fiscal, and operations. So that's her title. And then we have a third administrator over eligibility and enrollment, who also operates MILES, the Milwaukee Center for Enrollment there. So we also then have bureau directors, and Alicia Burma runs our Bureau of Quality and Oversight. So she and her folks tend to take a lot of the complaints about how things aren't working right, which we hope in turn, I know, she's great. So we hope that with that oversight through Alicia's bureau, we take what's not working right and incorporate back into how our program operates, and make it a better program to serve the people of Wisconsin. So that's sort of how where we fit in terms of the Medicaid space. What we had planned for you today was a presentation on what's changing in Medicaid. And we have to say at the outset of this that we have federal changes that have happened with the new president and his federal administration under President Trump. So they have laid down some important changes for us to follow in the Medicaid department. We've had some state changes along with our state budget that was passed. And then Alicia's going to go over also some long-term care program changes that happen. So if you think about how Medicaid works with the federal government, we call the Centers for Medicaid and Medicaid Services, or CMS, we take direction from them, and anytime we want to do something within their parameters, we write what's called a waiver, but we have to get permission from them in terms of what the program is allowed to do. So it's a partnership with the federal government. So I also want to say that some of the federal changes that we're going to talk about are we're still waiting for guidance from the federal government, so they can say something like, we need to have work requirements, but we still need to wait for guidance in terms of what they will find acceptable in terms of a work requirement. So just to note that we're explaining some of what we've been told, but we're still waiting for additional guidance on some of the, on some of the changes. So the first thing to note is obviously the federal government shut down on October 1st. However, we still are operating Medicaid at the state level, and most of the people that we work with at CMS or the federal government are still working. So for the most part, our operations in CMS and DMS, the Department of Medicaid Services, are not affected. There are some issues with food share, food stamps that are affected, and we'll talk about that in a minute. Just to note too, our website is where you can get the most up-to-date information, and that's listed here. So, he wants to come in. I know, I'm a really exciting speaker. They're coming in from all over. Okay, so the One Big Beautiful Bill, as it was first branded, I think it's since been branded as a working class or working families tax cuts. But most people know it as the One Big Beautiful Bill Act, was passed on July 4th. And it did make changes to who is eligible for Medicaid and food share. It's a little bit complicated in Wisconsin because a lot of their changes affected states that had expanded Medicaid services under previous administrations. Wisconsin opted not to expand formally, so many of the changes you hear about in the news did not affect us in Wisconsin. We were, in Wisconsin, able to expand some services outside of the formal expansion that other states pursued. So we're gonna present what we know right now on Medicaid and food share eligibility rules, and keep checking our website. So one of the biggest changes for both food share and Badger Care Plus are these new work requirements. So members ages 19 to 64, if you don't have a child under 19 who lives with you, you're required to report about 80 hours of work a month, training or volunteering. We have a lot of exemptions for folks who have disabilities and other ways to be exempt from those work requirements. And again, we're still looking at how the government wants us to effectuate these changes. So the things we're trying to think about are, is it gonna be every 6 months where you report? How are you gonna report into our system? We haven't built that yet, right? So a lot of this is still to be determined. The other aspect that One Big Beautiful Bill put in was there's no payments for healthcare providers who are mainly engaged in family planning but provide abortions. So this is where you might have heard that Planned Parenthood has stopped providing abortions in Wisconsin so they can continue to get paid by Medicaid for family planning services. So that was definitely one of the aspects of One Big Beautiful Bill. The other aspect of that did affect us is retroactive coverage was reduced from 3 months to 2 months. So that means sometimes when you apply, people don't know they're eligible for Medicaid until they have a health emergency or health event. And once they apply, we used to give them a 3-month look back, right? So if they had bills in the 3 months prior to that health emergency, we would cover those services. Now they're saying we can only do that for 2 months. In addition, there was some changes to the hospital assessment and how that happened. The hospital assessment is how we can collect some money and redistribute it to hospitals that are serving Medicaid folks. So food share had similar expansion of work requirements. This is one of the things that you need to watch the news on if you are a food share recipient. The money that's loaded on a card for food share is entirely federal money. And so with the government shutdown, we're waiting to see if they will release that money or not in the coming months. So that is a situation we want to watch the news and our website to make sure folks who have that benefit are still eligible for, or still able to receive that benefit. Another aspect of food share is the shifting of some of the costs of administering this program onto the state. So currently, a lot of how we administer food share is funded by the federal government, and they're asking us to look at things like reducing our error rate in a caseload in terms of maybe we gave someone a benefit in error. The greater error that we have, the more money, the more money they're asking us to pay for those cases. So there's going to be some focus on quality control to make sure we reduce our error rate. Let's see. So I think this is the last of my slides before I let Alicia jump in. What we're asking you to do is to keep your information up to date, or your client's information up to date with the state, so that you continue to get all the notices that you'll need to get in terms of if you would have a work requirement in the future, or if changes to benefits occur in terms of your food share. So you can do that through My Access, the app, or you can do that on our website to just make sure you keep all your information up to date. Okay, I'm going to turn it over to Alicia, and then I think we're hoping we'll have time for questions at the end.
Thank you. Okay, here are some resources for you all. There's a specific website for Food Share. There's one for just on Medicaid news. And so just for your awareness, there's a lot of great information out there, and we are keeping it up to date so that you can get the most recent information. So I'm going to focus here on what's, oh, you were going to talk about the state.
Okay, well, I did get a little break, and you got a break from me. Okay, so in the state budget, every 2 years, we create a new biennial budget. So it's a budget that covers a 2-year period. We signed this budget, or the governor and the legislature signed a bipartisan budget on July 3rd. The reason that that's important is because we needed to have some information in the state budget that we needed passed before the federal budget passed. So it was a timing issue for us, and we were able to get that done. We did get the majority of our costs to continue Medicaid as a program in that state budget. Okay. So it also, with the funding that continues the state Medicaid program, it increased the hospital fee that helps us pay for Medicaid services. So we, again, that's hospital assessed. We assess the hospitals and then redistribute that money based on how many Medicaid folks people see and serve. Did I go the right way? I think so. Okay. There were some increases for to Medicaid rates for providers within certain areas. And these are several of the areas that received increases. Okay, now is it you? Okay.
So Nicole talked a lot about, kind of what's happening on the federal and state levels related to kind of big changes, right? I'm going to focus a little bit more on some of the programs that you all might be connected with and talk about some of those changes. So first, I'm going to talk about family care. What's new in family care? So one of the things that's new is there was a request for proposal, which is really just a request for companies to apply to provide family care services in Service Regions 2 and 7. Service Region 2 is the southwestern part of the state, so I think of Grant, Lafayette, those counties, and then it also includes kind of the western parts, a little bit north, so Clark County, Pepin, those counties. And so with this expansion, we're expanding the number of family care MCOs from 2 to 3 MCOs in the west and the southwest, and expanding the number of family care MCOs from 2 to 4 in Milwaukee. So Milwaukee is Region 7. We're also expanding partnership program to an additional 14 counties in the west and the southwest. As a part of this request for proposal, it's now kind of on pause because there was a protest, and that means that any entity who didn't like the results of the request for proposal can protest it. And so right now, we're on pause because with this expansion, but it will be going forward at some point, hopefully soon. Okay, so family care waiver changes. So what is a waiver? Nicole mentioned earlier, it's really permission from the federal government, from CMS, to allow us to run a program. And so there was an updated waiver, and there were changes within the waiver for family care that were effective starting January 1st of 2025. Some of the major changes that were within the waiver and started on January 1st, 2025 is one, they made changes to competitive integrated employment. So it's now an independent service, and we've updated kind of employment services within the waiver. The purpose of that is really to provide more access to individuals to employment. That's really important for folks to get out in the community if they want to, and to access and to work. So for folks who want to, there's more services now in the waiver. The other thing is that we created a health and wellness service within family care, and that includes things like yoga, it includes things like exercise, it includes other wellness things that folks can access if they qualify. So that's exciting. We took kind of the old services and updated them and added wellness services to it. So folks have more access to that. And we also expanded options for covering technology. So there's more apps that are, applications that are available that folks can get through family care. In addition, we added transportation network companies, that's Uber and Lyft. And now folks can access and get transportation through Uber and Lyft. That's really exciting because it allows for more transportation. One of the things that I heard last year when I was here at this conference is that transportation is a big, huge barrier for people. And so this is one of the changes that actually came out of the discussions that we had here last year. And also added individual drivers as providers of community transportation. Again, trying to expand that pool of individuals who qualify to provide this particular service so that it's as flexible as possible for individuals in family care to get transportation. All right, so what's new in the IRIS program? There's a number of things that are new and happening right now. One is the FEA procurement. So we're moving from multiple FEAs to one FEA in Wisconsin, and we currently have a request for proposal out. Again, that is where entities can apply to become that fiscal employer agency. And we did this because we received feedback in 2024 on a survey that went out widely to individuals to provide feedback on their fiscal employment agency services, as well as a request for information, which was sent out to any entity who was interested in providing the service in the state. And the benefits of a single FEA is consistent processes and practices for participants, participant-hired workers, billing providers, and ICAs. So we heard a lot about how it is very confusing out there to have multiple FEAs. By having one service provider in this area, our hope is that it makes it easier and it streamlines it. We also hope that it enhances program integrity and that efficiencies of services and economy of scale. So we really want to make sure that people have access, that it's easy to access, and that we're able to hold accountable the fiscal employer agency who's providing the services. Right now, this procurement is in process, and so we've had applicants apply, and it's now in the process of being evaluated. So I don't have any updates at this point in time in relation to who that fiscal employer agency will be. We anticipate knowing who will be chosen probably the beginning of next year, and we don't anticipate that this service will roll out fully until 2027. Similar to family care, there is currently an IRIS waiver renewal. So where that waiver for family care went into effect on 1/1/2025, we're hoping that this waiver goes into effect on 1/1/2026. So the IRIS waiver renewal process started in July of 2024. We had robust public input. So we had more than 150 people attending 2 online public input sessions in July of 2024. We had over 2,000 people respond to an input survey in August of 2024. And then we gathered input on the waiver renewal application during a 30-day public comment period that included anybody, including tribal consultation, from July to August of 2025. So we got a lot of input from folks around the state. And the proposed waiver was submitted to CMS in September. It's now in CMS's hands. And what's next? CMS will review it, ask us questions, They will approve or request modifications, and when approved, it will cover years 2026 to 2030. What you might see that's once it's approved is first many similar changes to the family care waiver that includes like increased employment services as well as wellness services. The other thing that we added, and it was based on feedback we received, was that for participant hired workers, there wasn't an overlap to allow one participant hired worker to train another one coming in, and that was really difficult. And so we wanted to have that overlap of participant hired workers being able to train each other to provide the best services for folks in the IRIS program. That actually came up as well last year, and that is something that we put into the waiver. So we're really excited about that. Let me just make sure. Another change that we made is within the background check policy. We received a lot of concerns and feedback that the policy was more restrictive than it was in family care, and that there were many participant hired workers who didn't qualify to provide services for people in the IRIS program because the background check policy was a barrier. So we more closely align the criteria with the family care program. We decreased the amounts and types of convictions that previously presented were a barrier for individuals to be hired as a participant hired worker. Most of those included kind of past drug convictions or past theft convictions. And we revised the process so that the participant is notified of what the background check unfolded, and then we're allowed to say, yes, I want to hire this person, or no, I don't. So the participant will now see the convictions and will be able to make the best decision for them whether they want to hire someone or not. The other thing that we changed is there's a process if somebody has had a past caregiver misconduct finding, that there's now a process for a rehabilitation review, which really just means that they can ask for it to be looked at and still become a participant hired worker anyway. So there is that flexibility as well, so that it's not so hard and fast. What we're hearing is that that the policy was really restrictive, and we tried to open it up to provide you all more opportunities to hire individuals that you want to hire. Finally, in IRIS, another big change is Acumen, who is a fiscal employer agency. They informed DMS that they no longer wanted to be a contractor for IRIS. And so we're in the process of transitioning about 1,800 people in the IRIS program to a different FEA. So most of those transitions will be completed by November 30th of 2025. There are two major projects that I wanted to talk to you all about and make sure that you're aware of. One is the provider enrollment project. Sorry. This is a requirement for all providers who provide Medicaid services for long-term care, so that would be an IRIS or family care, to register with the state of Wisconsin and get a Medicaid ID number. Previously, they could go to a managed care organization and become a Medicaid provider through the managed care organization, but they'd have to go through multiple managed care organizations, or they'd have to go in multiple places to apply to be a provider in IRIS. So this requires that they enroll one time with the state, and then they're able to contract with any of the IRIS consultant agencies or the MCOs to provide services for home and community-based services. This does not apply to participant hired workers in IRIS. So I just want to say that anyone who is a participant hired worker within IRIS does not need to enroll as a Medicaid provider. So why is this change important? First of all, it streamlines things for providers. So it makes it where providers only enroll once and they enroll with the state. The state also then knows who all the providers are out there providing services. Right now, we don't have a good sense of all the providers out there. And it also is required because we need to follow federal rules, so there is a requirement to have this enrollment process. So we need to go through this process. Enrollment is really easy, and we've created a lot of resources to assist providers to enroll. And this slide just sort of highlights how providers can enroll. We are encouraging providers to enroll now, and the key is to enroll as soon as possible and get the support through if there are questions. The second big project I wanted to highlight is the IDD Mental Health System Improvement Project. This project aims to improve the systems and services for people who have dual needs, IDD and mental health needs. This project has been going on for many years, so you might have heard of it before. We're really proud of it. There was a Wisconsin IDD Mental Health System Improvement Report that highlighted 37 recommendations to improve the system for individuals. What we were finding is they weren't getting the right services at the right time, and so people were and are not getting the help they need in the best way possible. And so we want to change this, and this particular project is very exciting because currently there are about 4,000 people who are interested in this project and helping to move forward these recommendations in we call the community of practice. And the current projects are a step down from crisis stays for up to 180 days. So what we were finding and what the report found is that folks were coming out of kind of institutions and not getting the help they need, and so then it was a cycle back into really restrictive places. So the goal of this is really to have a step down so that place for people to acclimate to the community and stop that cycle of going in and out of institutions. The second subcommittee is working on training and mentoring and collaboration between current professionals, so psychiatrists, psychologists, social workers, nurses, really need to connect about working with the IDD and mental health populations. We found that over the years that there's not that support for each other to make sure that best practices are being used to provide the best services to people. And then finally, Subcommittee 5.7 is working on a free training for people who provide direct care to individuals with IDD and mental health needs. This will be up on the State of Wisconsin caregiver portal, and people will be able to take this hopefully in yes, I'm glad that's exciting, but will hopefully be up in the next 6 to 9 months, we're hoping. So that's very exciting. So anyone can get involved in this project. I encourage folks to join this movement to make systems better for people with IDD and mental health needs, and you can check out the website. But if you type in IDD Mental Health Wisconsin, this should come up right away. There is a place that you can sign up to get notices about what's happening and how to become involved in this project. So we hope that all of this information has provided some clarity to all that's going on each of the different levels, from federal to state to the programs that we run. We know it's really confusing, and you probably have quite a few questions, so we are happy to answer any questions that you might have. All right, I see someone here in the front. I'm going to put on my glasses so I can see better.
So with my status, would I have to do the work requirements?
So there are a lot of exemptions to the work requirements. And so most individuals who are in long-term care programs, it probably doesn't apply. Let me give this to
Yeah, and I would say if your status would ever change where you would need to, something about your eligibility changes, you would be notified. So you would know for sure if it was a requirement that you would have to meet or not. But unlikely for people in long-term care that they would need to fulfill a work requirement. And remember, we're still waiting for guidance from the federal government on what that means, what they'll accept, if it's volunteering, what type of organization that would qualify for. So we're still waiting for all that information. Oh. Okay, sorry.
Was he asking about the new work requirements? Sorry, I got late. But was he asking about the new work requirements that are going to be implemented under the Medicaid cuts? Because I was wondering about that too.
Yep, I think that was the same question. So if you need to meet a work requirement, you will be notified of that, but unlikely for folks in long-term care. I know. Do you want to? I think we have some this way.
Should we do a tag? You guys, we can baton it. I've never was we can pretend I was 40 in my life.
Well, actually, I happen to know, I think I know a little bit about your question, Chad and the other gentleman. If you have an EBD determination, that's elderly, blind, and disabled, and if you would know it if you're getting Social Security, you have to. I know I have one. I would have to get MAP Medicaid. So I know I'm not going to have to work. Me at work, I am anyway, so I'm covered. So, but if that answers your question, other question I have is the one big beautiful bill stuff. What does this mean? I hear you, Mark. But what does this mean for people?
For the other, Mark just said one beautiful bill sucks. But I just want to make sure.
I've heard him be called one big ugly. But anyway, I'm just trying to figure out what the. It's probably in its infancy by now, but I'm trying to figure out what order of selection they use, because I know DVR uses order of selection for cutting and what priority lists they do. Also, they're going back and forth about 182 billion and 180 billion. I'm just choking up on another serving of number soup on that. But we're the people that use what the Republicans are talking about, aliens, because think about it. You do the math. What are our bills? They're in the billions, no doubt. So one can't help but wonder, when's it going to take time? Assuming Chuck Schumer fails at his mission, I don't think I approve it 100%, but because it's kids at play, but it's their last thing, I think. But still, what does this mean for us if they cut that? And then where do they provide care for us? Are they going to go to institutions under contract? How does that work? Does any of this?
Yeah, I have a microphone. Even though I have 4 kids and I thought I could yell loud, this helps.
It does.
So I would also just caution the federal numbers that you hear about Medicaid cuts largely does not apply to Wisconsin because we did not formally expand. So we just need to be careful about, what we're talking about in terms of how it affects Wisconsin. Right now, we don't have any plans to make cuts in the Medicaid program. I think we expanded in a smart way that was not in the formal way that other states did. So currently the way many of the large numbers that you're talking about have to do with states that formally expanded Medicaid. And we are still waiting for other information to come through the feds to tell us how things like work requirements will affect us.
So we have about 20 minutes.
Okay, I'm here. Yeah.
All right.
MAP Medicaid is a little bit different than EBD, but
You still have to have a disability determination that's EBD, right? For that?
I would have to confer with my eligibility colleagues. Remember, my job is benefits and service delivery.
Okay.
So we have a question
Yes.
from
Okay.
So, just looking at the things that you're adding to Family Care and Iris for the wellness and health information, can you talk about kind of what programs and what things will people be able to ask for under that?
Yeah. So again, yoga is one that comes to mind. Kind of access to exercise, access to, I think Reiki is a part of that. I think that there's access to therapeutic massages and things like that. So, but it would need to be approved. So just to make it clear that it would need to be approved through.
So like paying for like a YMCA membership or something along those lines?
Correct, yeah. A yoga class, an exercise class, someone to help with learning to lift weights in the proper way that's safe, those things.
I misspoke, and you have 40 minutes. We're 2:30.
45. Oh, I thought we only had 45.
Yeah, I thought we
No.
only had 45.
It's
too,
a
but-
team effort here, her friend. Okay, I'm gonna go this way and then to you.
We're all good.
I think I'm trying to keep, I'm trying to keep track.
Hi. So I know that part of the IRIS waiver renewal was changes to the definition of support broker services. And my understanding is that part of that would be excluding the assistance for employer-employee responsibilities and services, which to my knowledge doesn't align with family care. Can you give us some information around why that would be happening and what the thought process was behind that?
Yeah, my understanding was the purpose of changing and refining the definitions was to make sure there were clear roles and responsibilities that were defined within the waiver.
And I'll just add that was under the direction of the federal government, that there was too much duplication between the support broker services and the other services that are offered. So also in reducing what's allowable for the support broker didn't mean we took away that service. It is provided under another category, right? Do you know which category? I think it's
Yeah, no, it's just within a different definition, so.
different provider type.
Yeah. So it's just aligning who is allowed to provide the services. So the roles of the IRIS consultant versus the role of a potential support broker.
So I just follow up. So when you're saying it's listed as a different type of provider, so in the waiver, there's a service description, service category, and then underneath those in the waiver, it's who can provide it. Right.
Yep.
So you're saying that piece falls into a different bucket of who can provide the brokering to get to that service?
It defines the service broker definition to provide what is allowable for a broker to provide, what service the provider.
So if you were a sorry, I really feel like I'm loud. If you were a support broker and you still are interested in providing those types of services, you can enroll as another provider type. The issue is you can't be a supportive broker and the other provider type at the same time, so you would have to make a choice.
Hello, thank you. My question is about the background check, the new policy. I was just wondering how those specific convictions were determined. On the list of convictions that have to be reported to the participant, the trafficking, and I'm just wondering what criteria, how did that happen?
Yeah, so it aligns with kind of family care and what how that works under family care, and it's a very complicated with level of conviction and those convictions are tiered in certain ways, but really what it's supposed to do is allow for the background check to identify if somebody has particular convictions, and some of those convictions are now allowed, that person is allowed to provide the service, but it's the participant's choice.
I can just tell you a couple stories in terms of how this came about. One, we're always trying to align our programs together because it's really difficult for for people inside DMS and outside of DMS to say, if you're in this program, then you can do this. If you're in that program, you can do that, without a real, like something as simple as a background check should apply to multiple programs. But what we were hearing were there were folks who had a simple theft conviction 20 or 30 years ago and had been providing services in the IRIS program, for example, and it was they wanted to continue to maintain that provider. So it allows the participant to have that choice now to say, of course, if you've known this person and you believe that they the theft conviction isn't something that they're dealing with, or you're actively worried about it, you could make that choice to hire someone. So we heard that story multiple times, and that was what led us to make some of those decisions.
So these changes that we're talking about to the long-term care and have gone into effect if already, and we're seeing some. I know I've learned just from being at the conference here at different vendors and people that were here setting up booths that these things are now available. Now you're seeing that this wellness part that is new.
Yeah.
And then another one that I found that was new while I was here was the transportation is different, and another one is the meals are added now. Those are available for long-term care.
Yep.
Was there a notice or announcement sent out to families so that they would know that these programs are changed, are available, and when will we find out that information?
Sure. Great question. So I'm gonna start with your first question, which is what's available now. So as we talked about, there's family care and there's IRIS. The family care waiver was approved and went into effect on 1/1/25. So those transportation, the wellness changes, what you're talking about with medically tailored meals, all of that went into effect for family care at the beginning of 2025. For IRIS, we're in the middle of the process for getting our waiver approved, and that's not due to be approved until the beginning of the new year. And so for IRIS, these changes will not go into effect until we think 1/1/26, assuming that they're approved. Yes. And then your second question is, how can you find out about this information? We do have this information on our website. If you are, obviously for IRIS, this has not changed yet, but for individuals on family care, you can talk to your care manager, and they'll be able to talk through the services. And it's also located on our website.
I do have a question on food share. When you're working, is there a cap on that? How much you can make and still get the food share? Because the federal government is forcing the handicapped person to work out in the community. But then is there a cap on that? To receive the food share?
Right, and so there are a lot of questions about the work requirements, both for Food Share and for Badger Care Plus enrollees, and that is definitely one of the things that people have identified as how much money they can earn right before they would lose the benefit. So we're waiting for guidance on all of those things. So I would assume that nothing is changing now until you're notified that your benefit would be impacted. Yes. Yeah. Right. You're right.
I have a question over here, and then Kevin, are you still in queue? So I'm gonna have you ask your question, then we're gonna go to Julie.
All right. You mentioned the rehabilitation review. Does that mean that the PHWs that were denied don't have to do another application? They just request a review for that application?
Yeah, for the background check, if somebody was denied based on the caregiver review, then they can ask the Division of Quality Assurance to relook at that. So yeah, that they can apply for that.
So they don't have to do that whole application again. They'll just go based off of the one that they did prior, reviewing that.
Who will do?
The PHW that was denied initially.
So if they were denied initially, then it was because of the caregiver, there was a problem with their caregiver aspect of it, then they need to appeal that, and they would appeal it through the Division of Quality Assurance. So they don't really reapply; they just appeal.
Okay, thank you.
Sure.
That's one of the very frustrating things about government, right? The Division of Quality Assurance is outside of Medicaid services too, so we work closely with them, but.
Julie, and then Lorraine.
Hi, everybody.
Hi.
Hi. My question is, where can we see what was submitted to CMS for the IRIS waiver?
Yeah.
Because, I know, Alicia, in the IRIS Advisory Committee meeting, you had said that it was going to be posted online with all the comments and stuff, and I've been unable to find it. And all I saw was the initial draft. So I just, with all the, advocates had a lot of concerns, especially about like the support broker thing now. And I'm curious about the way you answered that question. Like under what service code does the rest of what a support broker is currently doing go? Or are you saying that that's the role of an IC? That's what I'd like to know.
Yeah, some of it is the role of an IC. And again, this was the direction of the federal government to us, saying that there was too much overlap with what a support broker was able to do and what an IC what is expected to do, and that we needed to clear that up. So that was definitely direction from the federal government. In terms of posting the waiver application, we haven't done that yet because we have not received comments back from CMS. So they could not approve big portions of what we thought we could do or want to do, or they could say this, we didn't clean up the support broker definition well enough, right? And we have to do that differently. So that's why it's not posted yet, to sort of reduce confusion. As soon as we have some sense from them in terms of how many questions they have, is it in good shape, then we can start posting and making that available for people.
Okay. The one thing that I'd just like to kind of clarify too, that whole relationship between a support broker and an IC is so fundamentally different, because IC is really an employee of the state, where a support broker works just for the person. And I'm hoping you're going to try to maintain, because that's really an important part of a person's dignity and their wherewithal to be able to live their life, is to have somebody be able to do that for them. Thank you.
Mm-hmm. Oh, there's
Maureen was next. Sorry, I got Lily's question, made my brain go to 3 other things in my head, and then I
know,
did
I'm
you have a
trying to
question,
get to
Maureen?
this lady too.
Maureen, then they're going to point back at that. You got it. Go, girl.
We're caught in a sort of a black hole, and maybe you can clarify. I tried to get my phone out fast enough for your slides, so if I could find that again. So Megan has a chiropractor, and we see on the FEA website the chiropractor has to go into Forward Health and become a provider. The chiropractor calls me and says, I have an MA number. I'm already a provider. I can see Megan's record. What hoop do I have to jump through? The FEA has absolutely no information. And so we've gone back and forth, and I'm thinking the chiropractor's going to quit, because it's been a lot of nonsense and no good information.
Yep.
So they're already a provider. Do they have to fill out a form? Where's that form? Why isn't it on the front page of every FEA? Let's have some instructions, not just a notice and a deadline. Let's have instructions.
Yeah, they really should be kind of connecting to more robust information about how providers can enroll. What I'd like to do is make sure I get your information and get you connected to the folks who can specifically help this chiropractor kind of get connected. it really is for home and community-based services. So if the chiropractor is providing that home and community-based service, then they are going to need to enroll. It's not clear to me for this particular chiropractor if they've already have enrolled or what that number that they're talking about is. So I really think we need to get kind of a better understanding from that chiropractor about what number that is, and we can work that through. So.
You got them confused.
Yeah.
They're already a provider. Enroll in what? You know?
Yeah.
Yep.
Yeah, sorry. I hear you and I understand. I think the confusion might mean they might be a Medicaid provider, right? And we're asking them to enroll in a long-term care provider network. So that definitely could be the confusion. But if we can get your name and email, we can hopefully help, or even the name of the chiropractor can help them.
Yep.
Yeah. I know, yeah. Sorry.
Hi, so I'd like to know what services you feel or what are the support broker is now supposed to be doing and that the IC is now doing instead, because we're told support brokers are only doing or can only do Medicaid reviews and food share reviews. And then who's supposed to do, I mean, we're consultants, we're not managed care.
Yeah.
So what is it that you're thinking the ICs are now going to do that the broker was doing? Give me an example.
So it's my understanding that support brokers have been providing a wide range of services, and some of those services align with what the ICs are doing or an extension of what they're doing or should be doing. And so some of those things are like providing support around, connecting to hiring participant hire workers and other activities that really should be going through the IRIS consultant agency or done by the guardian or the participant, because it is a participant-run program.
So we had seen some of the guardians shift responsibility onto the support broker, kind of creating this false sense that somebody else was helping and in charge when that really wasn't what the support broker should be doing. And you're exactly right. What we're asking them to do is any type of other program application. If people are eligible for other energy assistance or other things, they could be helping with those types of things. That's absolutely appropriate for a support broker. Most people were doing it right. I think that's the other thing we have to remember, right? Most support brokers were operating within the role we felt they were, and then there was, a couple bad actors, right? That we just need to make sure we are clear. Again, that was the direction of the federal government.
If the scope of the support brokers is kind of narrowed down, and then the consultants are kind of expected to pick up that function then and cover that work task. Do you know if the state would reduce the caseload for consultants? As a former consultant, I know 47 to 50 participants is far too many to have the time to do any of that.
Yeah, I'm really glad that you brought that up, because that is an issue that I'd like to continue to look at. What type of caseload is appropriate?
Yeah, and it's my understanding that there is, like, within the requirements that an IC, an IRIS consultant agency, can make those numbers lower.
Right, and I would say that they are supposed to post those numbers on our website, right? So you should be able to look at the different IRIS consultant agencies and what their ratios or caseload are, and there is quite a bit of difference, right, depending on the agency that you choose.
And I guess mine isn't so much a question, but it's a comment to that. So like I work for Inclusa. At our site, so for us, we have staff that then are dedicated to just assisting people to do those types of things. So when you reach out to us, we don't have support brokers that do any of that.
That's right.
We have employees that assist with that.
Yep. Yes, and that's true of a lot of the IRIS consultant agencies. They set things up differently, and so the caseloads, it doesn't necessarily tell a full picture. In some, they separate out, like what you're talking about with Inclusa, certain tasks to be done by different folks other than the individual IC.
Hi, thank you, Patty. I just want to say thank you for being here. I have a question regarding the Medicaid portal. I work for a managed care organization, and I just got the list yesterday of our list of providers that are not yet in that Medicaid portal, and it was quite alarming to me. So I'm very concerned that by January 1st, we're going to have a lot of providers that are not in that portal and what that looks like. And then I also am wondering, I knew Lyft and Uber were options for individuals now. So is it the company that's in the Medicaid portal, or does each driver have to be in that Medicaid portal?
No.
Because we just have a number of providers that are not, and actually our care teams are getting calls about that, which I think is interesting too, because it's not an MCO requirement, like this is a DHS requirement, correct?
Correct.
And then we're trying to transition from a big vendor that we used was McKesson, and they are not going to be a contracted provider. So we've got a lot of transition happening for individuals right now, and a lot of that comes back on the MCOs, like, you did this. So there does seem to be a little bit of where this is coming from, and the MCO is trying to adhere to what's been passed down to us. So.
Yep. So the provider enrollment project, thank you, is initiated by the state, and it's to fulfill certain requirements. So that has to do with the state to be able to know and understand who is a provider providing Medicaid services for home and community-based services. In relation to the transportation question, individual Uber and Lyft providers do not need to enroll separately as long as the company has, and we are working with Uber and Lyft to make sure that they're enrolled. There are a number of providers who still need to enroll, and that's why we're encouraging providers to enroll now. And we're continuously looking at this and making sure, and we're doing a huge push. There's going to be a couple more town halls to help providers coming up. There's also videos online to help people. There's lots of resources, and hopefully some in-person locations where individual providers can get assistance. So there is a big push now to get providers on board and to enroll. And so that's really our push and focus at this point in time.
Yeah, I would just ask, and we are at the state working with each MCO to determine which providers still need to enroll and developing plans for that as well. Our goal is to not disrupt services for members, so actively working on making sure that happens. Also, just to be aware, Uber and Lyft it can be used in the family care program for community engagement rides, still not for medical transportation, right? That's a different benefit and different service that happens through our vendor MTM, which is also another confusing way, right? When folks need a ride, depends on what it's for.
My question is around the background check policy. So for individuals or PHWs who are under the appeal process, will they still be able to provide cares to participants during that time, or are they going to be not allowed to work? And then what happens should the appeal be denied and they're not allowed? So what is that process like?
Yeah, good question. So if somebody is denied, then they will not be able to provide that service. In the meantime, what we've been doing is we've been working on those individual cases separately and working with the Division of Quality Assurance to make sure those go through as soon as possible, because we don't want to disrupt the services for the individual. So we're trying our best to kind of balance what Medicaid funds can go towards, and then also making sure the process is completed as soon as possible. So yeah. Fortunately, we haven't had many of those appeals, so I'm going to say that it's not been a major issue so far.
You said with Uber and Lyft, do you need like a special card to use them? And how do I get that?
So Uber and Lyft is for folks in family care, and it would go through your MCO. So your MCO would let you know if they wanted an account set up, or if you could directly contact Uber and Lyft. So it runs through the MCO at this point.
So family care.
For family care only. Yep.
I was going to name some, but then I would miss one and I'd feel bad. Hold on there, Nancy.
Sorry. So if If someone in family care is using the Uber Lyft option, is it only for that individual, or is it for someone to go with them?
Oh, they should be able to, when they schedule their ride, say that they have a person with them. The one problem that Uber and Lyft and we have with our MTM provider is when folks have a number of little kids or other people that weren't planned for in the ride. So there's always an option, right, to say, you know, if you're getting picked up at the same point, right, to list that person as somebody that's going to be in the ride.
Okay.
I don't know if you're asking if they could get picked up at 2 different locations. I don't know the answer
No,
to
I'm
that.
saying
Oh, okay.
if my daughter
Yeah.
requests a ride and she needs me to go with her because for whatever reason I can't take her in my car, I'm allowed
Right.
to go with her.
Oh, sure. Yeah.
Okay, my other question has to do with the wellness thing in family care. When you say it has to be approved, and how do we find out what's an approved product that they can utilize in wellness and exercise or what have you?
Right, just like for any kind of service that's approved through your managed care organization, it just has to go through. It would be a conversation. It would be based on need, whether or not there's a need for it, and that decision is made through the care coordinator.
Okay.
Yep.
Anybody else have some questions? Anybody want to say something great they enjoy about their long-term care? Because we are the very few states have one that looks like this, and we have all these people interested and ready to help it keep growing. Hi.
So the Uber Lyft, you said that's only from like family care, not Iris?
Correct, because the IRIS waiver has not gone through yet. So there's a bunch of changes for IRIS that will go into effect once it's approved by CMS, so Medicaid, the federal Medicaid entity. And so once it's approved, and we anticipate, although we're now in a shutdown, so I can't guarantee it, but traditionally what happens is CMS approves it before the end of the year, and then the waiver goes into effect at the first of the year. Because we're in such a unique circumstance, I don't know for sure, but that is that's how it's worked in the past, and we hope it will work now. So once 1/1/26 comes along, then those services will be available for IRIS. Yep.
So do you know how they're going to like bill that, by the mile, by trip, or?
I think that it's by trip. Yeah.
So the other thing to be aware, and right, IRIS is a program where participants take on a certain amount of risks, is Uber and Lyft are monitored differently, right, than our MTM drivers. So in some ways it's better in terms of someone's consistently monitoring the speed of the driver. In other ways they don't have drug tests, for example. So you hear, you have to just be aware of a participant using Uber and Lyft and what the risks are. I think we hear more often from people that it increases the amount of drivers, like Alicia was talking about, that can provide rides, and it eases some of the congestion we have in that system for that. But there definitely is a difference in how MTM monitors drivers versus Uber and Lyft. Oh, yep. You want to do this one first? Okay.
I just wanted to ask for family care members that are using Uber and Lyft, how can we afford those when they're very expensive? And when there's issues with the drivers, how can we report those issues?
Right. So you would work with your managed care company to determine what your account looks like, and then how to report back issues. It is a little bit different, right? And remember that those rides are not for medical transportation; they're just for community engagement.
Yep. So again, you can talk to your care coordinator, and that care coordinator will help identify what rides and approve whether rides are approved or not. So just like you work with your care coordinator for other services, you would do the same for Uber and Lyft.
I can't resist sharing this tip, but I was talking to someone yesterday who rides in a lot of Ubers and Lyfts and different things, and I didn't know this, but if your Uber or Lyft driver turns off the app, that is no longer an insured ride. So sometimes, I know, right? Sometimes the Uber driver has like somebody they know that has their personal number, and they can say to you, if you're in the I'm going to turn the app off because I'm not going to, Uber doesn't know I'm going to pick this person up, right? And the person I was talking to was like, I'm like, nope, you keep that on. I'm going to pay the extra $5 because otherwise you are uninsured in that car.
Huh.
I know, right? Things I learned at the SD.
Yes.
All right, Mark, you go. Question.
Just to elaborate, Uber and Lyft, their options. I don't know how many people know this, but if you're in a wheelchair, they don't have WAV vehicles very many places. Even if you're in Chicago, you probably have to be picked up at around the Willis Tower and dropped off around the Willis Tower, just to give you an idea of where drivers are. So for a lot of y'all that can use it, if you are ambulatory, that's great. I don't know how many people know about the wheelchair accessible vehicle situation.
Sounds like a micro enterprise opportunity. I'm just
Yeah.
Yeah. No, I think.
And then they're all minivans besides, like with them. So people with oversized wheelchairs may not fit in a minivan.
That is
So-
true. And yes, thank you for bringing that up. I know that there have been conversations across the country with Uber and Lyft in relation to having access to accessible vans. So that is something that kind of, as I'm looking at things on the national level and kind of some of the national associations are really working hard on that. So the hope is that it will change.
Hi, I had another question just to follow up about the support broker piece. I know you mentioned that there were some bad actors, and so I recognize that can happen. I guess I'm not clear, I guess, on the CMS piece, though. I'm looking at Medicaid.gov. There's a piece in here CMS has put out called the Key Components of Self-Directed Services that speaks about support broker services, and just to quote part of that, it says, for example, providing information such as available resources, counseling, and employer-related skills training can result in the individual and representative, as applicable, becoming more educated and effective users of self-directed services. So are they now saying something different? Or?
So I would say that most states use the definition of support brokers the way that we use ICs. And so that was part of the confusing part for us when we applied to redo the waiver. So other states use the term support broker to mean what we mean when we say ICs. Yeah, it's to make it more confusing.
I feel like I should make amends, y'all, because I actually wrote that part of the IRS waiver in the beginning of time. And
Thanks,
it was
Patty.
based on the Dane County support broker model.
Right.
So I'm really sorry.
Yeah.
My amends from something I did 20 years ago.
I guess just can we clarify though why it would be allowable then in family care and not IRIS for the support broker services? And I don't think it's overlapping ICA responsibilities, it's overlapping employer authority, which is the participant.
I was listening.
Yeah, so
This is really...
We had some other people asking questions
Yep.
up here, so I didn't.
Yeah, it's okay.
Yeah, in relation to your first question, which is it's different from family care and IRIS, that is something that we are looking into, so thank you for that. And your second point in relation to like it's looking at kind of, it's covering some of the things that IRIS consultants do, and then also some of the things that like a participant or the guardian are required to do. Is that what I'm hearing your question is?
Yeah, it's employer authority, not IC services, like recruiting workers, hiring workers, overseeing the workers.
Yep.
So that's the overlap, it's not.
Yeah, for that, that's the role of the participant to hire and oversee that, or their guardian. So I think what the waiver did is it kind of defined kind of the roles into different areas, and so some of the roles that were related to the IRIS consultant, and others were related to what is the responsibility of the participant or the participant's guardian.
So if you can't find your own workers, the support broker could or couldn't help you.
with the way that it's listed in the the current waiver that is being submitted, it defines it it would not be allowable as a support broker. Yes.
I think only a participant can decide which program they're better off in, but Family Care does offer that support, right, to help hire workers. Correct. Yeah.
And there's no such thing as any overlap in the family care world where, oh, somebody can help me refer me somewhere at least. Versus you're an Iris, you're all around the people. And if you don't know the right people, that's a barrier.
Yeah, so and the IRIS, yeah, it's my understanding that the IRIS consultant agencies are supposed to help individuals connect to resources around where they can hire.
You said community involvement. What does that involve? Like
So-
what, for example, what does it include?
It would be any appointment that's not to your pharmacy or to a service, right? Like a doctor's appointment or a hospital visit, anything outside of that. So if you needed like the health and wellness visits or other types of community interactions.
So I go to bingo on Thursday nights. Would that include that?
I love bingo. Yes.
Bingo, it does.
Yes.
I'm gonna go like way back to the first slide, I think.
Okay.
Sorry, just
It's okay.
total off subject. So we were talking about like federal changes to Medicaid, and I know that there's been a lot of talk, and I live in a really rural part of the state. So I guess maybe some reassurance or thoughts about what is being done to protect providers in rural areas of the state, because we have we've already seen providers go away in our part of the state. So I'd just like to hear some of
Well,
that.
I can talk about a little bit about the efforts I've been involved in with rural areas. So we've done Alicia, as to several Medicaid visits out to rural areas. We were in Adams County recently, in I want to say Lafayette County, to talk to providers there, dental and other providers, and listening to the needs they have to stay in. I also was up in Ashland, Wisconsin, where one of the issues they brought up was that the majority of their properties are being converted into Airbnb spaces. So even when providers want to come in and move their families in, they don't have housing for providers. So definitely issues like that. So we've tried to pull together some resources too to help rural behavioral health providers, for example, with some IT infrastructure and other things to help make it easier. And one of the things we heard was that often the office assistant is also trying to do billing, right? And that person can turn over. So we're going to try to provide some more resources there to keep providers. Then the second thing I would say is the Secretary of Health just sent to the governor's office her proposal for the Rural Transformation Grant, which is several $1 billion from the federal government that's supposed to be put back into rural areas to help providers stay afloat. And so we'll see what the governor approves for that to come through, but we should get some money there to be able to distribute it to rural projects to help providers stay open. So those are the things I know about that I've been involved in.
Any other questions? We're at like a 2:20. I don't know, 10 more minutes or so. I'm coming. I promise I'm coming.
You talked earlier about expectations for Medicaid. Is there anything different to expect for the Medicaid purchase plan?
Oh, the map.
The map?
Yes. So the map premiums, we did some of the system fixes in the October CARES release. So starting in January, folks should be getting notices again if they or they should be getting notices all along if they'd owed a MAP premium. But folks could definitely start to lose benefits by February if they're not paying their MAP premium. Hopefully, if someone can't afford a MAP premium, they're checking to see if they're eligible for other types of Medicaid there, but you'll start to see those changes come out January 1st in terms of us having to enforce, if someone doesn't pay their MAP premium, a loss of benefits. So we did build in a month period where if someone doesn't make their payment, we are giving them a little bit of time to catch up. So because what was happening was someone paid 2 or 3 days late, right, and the payment wasn't processed, then they were cut off. And obviously for long-term care folks, that's devastating, right, to have to reestablish their Medicaid benefit and then get back into long-term care. So we're hoping that we have the bugs worked out of that system, but that will MAP premiums and enforcement of payments will definitely be turned on January of 2026. So I don't know if I'd say anything different, but definitely the enforcement will be turned back on.
Back at you, Matt.
You say, I hear Medicaid fraud. What does that mean?
Well, Medicaid fraud, we talk about Medicaid fraud, waste, and abuse. And fraud can be simple things like a provider bills for a service when they didn't actually provide the service. And so we had several high-profile cases of Medicaid fraud recently that I think has brought this back to people's attention, where providers were getting people's Medicaid numbers and then billing as if they provided them a service when they didn't. And for some of these providers, they were billing well over $1 million in services that they did not provide. So that's the type of things that we talk about in terms of fraud. You have to remember, most people do the right thing.
But fraud can happen anywhere.
Yeah.
So what is your question?
My question is, why does it got to be? Yeah.
So the question, fraud can happen anywhere. Why are they focusing on just this particular type?
Put this kind of energy when I'm guessing what sorry. I think what he's saying is maybe we're going after fraud and we're spending more going after the fraud, given what's going on and it happens everywhere, than we're getting benefit for.
Yeah.
And you know, I think EBB comes up. You just brought up EBB. I heard EBB from my right channel. It's so easy, by the way, to defeat that. It's pathetic. A lay person can do it. You don't need a computer hacker. Given all this and pay rates sagging, people not making living wages, one, I do have to say myself, one has to wonder, why put all this into fraud prevention? Is it worth it? Are we spending more on it, going after it, than we are really getting benefit from it? And that's what I'm wondering sometimes at times, because I don't do anything wrong, but I'm sure they're questioning everyone on payrolls, including me. I don't mind, but it gets to the point where, folks, what are we really gaining?
Yeah, I think there's others that would agree with you in terms of how much money we spend on fraud versus how much money we gain. I think we also have to remember we operate in a political environment, right, where there's an opinion that any amount of fraud is too much fraud and shouldn't be tolerated, and certainly don't want to encourage providers to continuous fraudulent billing. I think where we're trying to help people distinguish is maybe a provider that made a mistake or didn't include documentation. That's not necessarily fraud, right? And we need to just work again with those providers to get the claims in a way that they can be paid.
Make you our last question.
I kind of think COVID impacted on how many people got in.
Yeah.
Was there a question that So thank you. We won't know that till we know that, I think is what I'll say on that one. Yes. Yes, that was my next. So you guys did great. You all did great. There is a survey.
Thank you for coming.
On your table, please fill out the survey forms, and Vicki and I can collect them, or if you leave them on the tables, we'll pick them up. Thank you very much, Alicia and Nicole, for being here and answering questions in person in all the ways.